So what I'm going to talk to you about, as Andrea said, is the state of referral guidelines, state of the art. And what I want to do is basically a quick survey of why do we need referral guidelines, what guidelines are available, what are some of the issues in developing DI guidelines, and what do I see as the future of DI guidelines. So we'll start with why. And the why relates to appropriateness, as Andrea said, and the concern that's widespread and has been around for many years, over a decade, that there's a lot of inappropriate use of diagnostic imaging. And this Eugenio Pequeno, who's actually a cardiologist, I think, from Italy, wrote an article way back in 2004, and he commented in that article that up to a third of radiologic examinations are totally and partially inappropriate. And this figure of 30% got quoted in Canada, and some of you may know created a lot of controversy. A number of Canadian radiologists objected to the idea that 30% of imaging studies in Canada were inappropriate. And the fact is we don't know how many are inappropriate. Jamie Fraser, who some of you may know, and I did a review of the literature on the subject, and we discovered that there are not many articles looking at appropriateness of imaging in Canada, and no comprehensive articles, and there was a wide variation in the amount of inappropriate imaging that was quoted in these articles. More recently, Paul Babin and his group from Saskatoon looked at specifically an MRI and did a systematic review of the literature, and they came up with figures ranging from 2 to 28% of inappropriate MRI imaging in Canada, depending on not the modality, but the subject that was, or the clinical condition that was being looked at, the place in Canada, and so on. So I think there's a wide variation in the amount of inappropriate imaging that's done. I don't think there's any doubt that there is some inappropriate imaging, and I'm sure you're all aware of it from your own practice. So we really don't know what overall is the degree of inappropriate imaging. We just know that there is inappropriate imaging being done, and the idea of referral guidelines is to try and reduce that and provide clinicians with guidance as to what is the most appropriate imaging and the most appropriate utilization of diagnostic imaging. So why do we care about inappropriate imaging? There are four main reasons. You don't want patients to be exposed to unnecessary radiation. Unnecessary exams obviously cost money, and we pay enough for our health care already. So if we can reduce those costs, that would be great. Across Canada, there are wait times for most of the advanced imaging, and if you can remove some of the inappropriate exams from those wait times, hopefully you can reduce the wait times. And the other issue, and I think is an important one, is the issue of incidentalomas. We all know what those are. We all know that we pick these up with appropriate imaging. But I think it's even worse to find an incidentaloma on inappropriate imaging. And I just love these two concepts, and I have to include them. The effect of finding an incidentaloma has been characterized as the cascade effect, a chain of events which tends to proceed with increasing momentum, so that the further it progresses, the more difficult it is to stop. And as you know, that's what can happen when you find incidentalomas. People say, well, what are we going to do about it? We've got to do further investigations to find out what's wrong, and the process can just continue to progress. Mercer Rang, who some of you may know, was a pediatric orthopedic surgeon at Toronto Sick Kids, called it the Ulysses syndrome, and I love this, I have to quote it. Called it that because patients with it, though healthy enough at the onset, make a long journey through the investigative arts and experience a number of adventures before reaching their point of departure once again, often with no great benefit. And it's a growing problem. This was back in 1972, he was talking about it, but can be prevented if the clinician views with suspicion the unexpected abnormal result. And I think radiologists should view them with suspicion as well. And how we deal with them is outside the scope of this lecture, but is very important. So that's why we need referral guidelines. So what's available? Well, there are a lot of sets of DI referral guidelines available. The main English language referral guidelines sets that are available are these. CAR, ACR, RCR, and Diagnostic Imaging Pathways. If you go to our website, the CAR website, you'll find our guidelines available. So as Andrea says, if you're interested in finding out and I would encourage you to look at them, the referral guidelines are for any particular area that you're interested in. You can go to the website and look them up. And we have, as you can see, basically they're largely divided up by body part or anatomical region, although we do have separate sections for cancer and for pediatrics. And the specific good guidelines look like this, in case you haven't seen them. We have a clinical condition, in this case suspected congenital malformation of the brain. We list whichever modalities are appropriate or might be used for this investigation. We indicate whether they're indicated or not. We give some information about radiation dose, and then we usually include a comment indicating why they're recommended. Perhaps, I'm sorry, I got up at 5 this morning to get here, so my brain is not functioning completely effectively. But why we recommend them, some caveats about their use and so on, and why we might recommend one imaging modality above the other. So that's basically what our guidelines look like. The American College of Radiology have had guidelines for many, many years, long before the CAR developed their guidelines. They call them the appropriateness criteria. You've probably heard of them. They are also available on the web. And you can easily go to look them up, and if you aren't aware of them, you can just Google them and find them. And they have a very good set of guidelines as well. Their format is a little different from ours, but they are good DI imaging guidelines. The Royal College of Radiologists in England have a set of imaging guidelines, which they call I-Refer. These are available on the web, but they're only available to the members of the college, or if you want to pay, you can also get access to them on the web, and they still produce them in booklet form. Diagnostic imaging pathways in Western Australia are another good set of diagnostic imaging referral guidelines. I will refer to these a little later on. They also have a slightly different format from our guidelines and from the ACR guidelines. The Royal College guidelines have a very similar format to ours. That's not surprising because our original set of guidelines were based on the RCR guidelines. We did revise our guidelines between about 2012 and 2014, and one of the members of your department was active in that process, and we thank him for it. So ours were revised, but the format didn't change, although the guidelines did change to some extent. So those are the English language guidelines that are available. As I say, these also are available on the web, and you can look those up through Google. So there are 3 sets that are available on the web. If you actually compare them, and I have compared them, taking a particular clinical condition and looking at the recommendations in each set of guidelines, they're virtually identical. There's not very much difference in their recommendations, which isn't surprising because they are to a greater or lesser extent based on the evidence in the literature, and they're all looking at the same literature and the same evidence. So although their formats are different and they cover different clinical topics, when you do compare topics that they all refer to or they all provide guidance on, the guidance is virtually the same. So, what are the issues with developing diagnostic imaging referral guidelines? And there are issues. The problem with diagnostic imaging referral guidelines are that they are quite different in their format and what they try to do from most clinical guidelines. And there is now a lot of interest internationally in the development of clinical guidelines. And as a result of this, and some groups have set up internationally recognized standards for the development of clinical guidelines. And the 2 major ones are Agree To and GRADE. And the problem we have is that these standards are designed for clinical practice guidelines that are developed by medical and surgical groups. And the clinical practice guidelines that these groups develop are very extensive. They basically, what they usually do is look at all the steps in the management of a particular clinical condition, like cardiac failure, for instance, how you diagnose it, how you manage it, how you manage the different manifestations of congestive heart failure. And these guidelines usually take a year or 2 to prepare. They're very extensive. They're usually often 50 to 100 pages long. And they, as you can imagine, huge resources to develop them. But these standards have been developed, and they are very high standards. And because those clinical practice guidelines are so different from diagnostic imaging referral guidelines, which deal with a specific issue, this clinical condition, what is the best imaging, the standards are very different, and the methods of developing them are very different. So I'll just show you briefly what Agree To is like, but I also wanted to show you, because I think it's interesting and important, that they're constantly revising these standards as well. And this is the consortium that developed the Agree To. There was an Agree 1, as you can imagine, and the latest edition is Agree 2. And you can see how many Canadians there are on this list. That the lead was Melissa Browers, who I know, who works for Cancer Care Ontario, and is also at McMaster. McMaster is a hotbed of evidence-based medicine. There are a lot of internationally recognized experts in evidence-based medicine at McMaster. George Broman in BC, Cancer Agency. You go down the list, Ian Graham, who at that time was with the Canadian Institute of Health Research, and I think is now in Ottawa, at the University of Ottawa. Jeremy Grimshaw is internationally recognized for his work on guidelines. He's at the Ottawa Health Research Institute. Hannah from McMaster, Coe from McMaster, McCarskey from Hamilton McMaster, and Dr. Zitzelsberger from Ottawa. So Canada is very strong in evidence-based medicine and in guideline development. So the AGREE-2 instrument has 7 domains. So when you're developing a guideline, a clinical practice guideline, you have to look at all these domains and try and follow these standards when you're developing the guidelines. And the number 3, the rigor of development, is particularly important, and this refers to how you do a systematic review of the literature to develop your evidence, how you grade the evidence, how you avoid bias in the development of the assessment of the evidence and development of your guideline. These are the kind of issues that they address. And it's a very detailed and difficult and rigorous process. And for all these groups who produce DI guidelines do their best to produce evidence-based guidelines, none of them actually match the rigor of the AGREE-2 instrument, or for that matter, GRADE, which is the other major instrument. GRADE is the grading of recommendations, assessment, development, and evaluation working group. There are a lot of Canadians involved in this too, but it's the list of members involved in GRADE is about 5 pages long, so I'm not going to show you that. And I think to show that there's an organization called Guidelines International Network that meets annually to discuss the development of guidelines, the latest standards in the development of guidelines, guidelines from different countries, guidelines in different clinical practice. And I've attended a number of these meetings, and the thing that always strikes me is that there's virtually no other radiologist, or maybe no other radiologist at those meetings. So I think one of the problems with DI guidelines as developed by the CAR, well, less the CAR, because at least I'm in touch with what's going on, but the ACR, the RCR, and diagnostic imaging pathways, that they're a bit out of touch with international standards of guideline development and the issues related to guideline development and the kind of rigor that you need to develop guidelines that will be internationally recognized and recognized across specialties. So I want to look at Holger Schoenemann, who is the lead author on this article, is also at McMaster and is also internationally recognized for what he does. And it's interesting that a number of people have been attracted to McMaster because of the strength of its work in evidence-based medicine from overseas. Holger is from Germany. Jeremy Grimshaw established his reputation in England before he came to Ottawa. So Canada has real strength in this area. Anyway, GRADE started out in the whole evidence-based medicine paradigm, if you like, started out by in an attempt to assess the evidence of the effectiveness of medical treatment. And as most of you probably know, the gold standard of methodology is the, my brain is not working, is the randomized control trial. Ideally, a double-blinded randomized control trial. And that's the gold standard for the assessment of medical treatment. And the standard, what they're looking at, is the outcome, patient outcomes, or what they really want to assess using these randomized control trials. So GRADE built on that basis of evidence-based medicine, and their first recommendations were all based on the idea, basically, the evidence they looked at and the way you assessed evidence followed this paradigm that you used randomized control trials, and the ultimate thing you wanted to measure was patient outcomes. So when they finally got around to looking at diagnostic tests, they stuck with this. They said, okay, the best way of measuring the efficacy of diagnostic tests is to look at patient outcomes. But if you think about that, that's virtually impossible to do, because diagnostic imaging, particularly if it's used for diagnosis, occurs right at the start of the patient journey, and there's a whole bunch of other stuff that comes between the diagnosis and the outcome, and all that stuff in between is treatment. So how can you possibly weed out the effect of diagnosis on the patient outcome in any reasonable, practical, and economical way? But they recognize that to some extent. So you'll see in that third bullet, they say that you can use test accuracy as a surrogate. So if you don't have any evidence on patient outcomes, and basically, except in studies of diagnostic imaging being used as a screening tool, there is no evidence on the effect of diagnostic imaging on patient outcomes. They say you can use accuracy as a surrogate, but if you do that, they downgrade the evidence, the quality of the evidence. They often provide low quality evidence. So this puts radiologists, diagnostic imaging people, between a rock and a hard place. So they say, we can't get evidence on the effect of diagnostic imaging on patient outcomes. You can use accuracy, but if you use accuracy, it's not high quality evidence. So basically, we're in the position where all our diagnostic imaging guidelines are looked down upon by the rest of the medical community because we just don't have good evidence, or what they consider good evidence. So it's a bit of a problem. And there's more of a problem than that, because in order to test, they have very high standards for testing the accuracy or assessing the accuracy of a diagnostic test, including diagnostic imaging. So valid studies of the accuracy of diagnostic imaging or diagnostic tests, including imaging, involve a comparison between the test or tests under consideration and an appropriate reference, sometimes gold standard. Investigators' failure to make such a comparison in all patients increases the risk of bias. Now, if you think about this in terms of diagnostic imaging, it's, I think, impossible to find a reference standard that will match that standard. Think about it. So you want to test say, the accuracy of ultrasound for diagnosing cholelithiasis. So what's the obvious gold standard? You take out the gallbladder and see if there are gallstones. Well, that's great. But what about all the people who have a negative ultrasound scan? Not many of them, and you'd never get this past an ethics committee, would be willing to have their gallbladder taken out to see how accurate you were with your ultrasound. And this, if you think about it, for most of the surgical things like cancer, appendicitis, the gold standard is what you find at surgery, but you can only apply that to the patient who has a positive diagnostic test and not a patient who has a negative diagnostic test. And if you think about a lot of other things we do, there isn't a good gold standard. We do a huge number of chest x-rays to diagnose pneumonia. What's a good gold standard for pneumonia? How are you going to diagnose pneumonia apart from chest x-ray? If you look in the literature, in some of the old literature, you'll find that people have actually done lung biopsies to assess pneumonia. But these were all very small studies, and you know damn well, excuse the language, you know very well that you'd never get that past an ethics committee. Well, we want to find out if chest x-rays are accurate for diagnosing pneumonia, so we're going to do lung biopsies on all the patients in our series, whether they have a pneumonia on x-ray or not. And if they don't, where are you going to biopsy them? So there's a huge problem with assessing the accuracy of diagnostic imaging tests. And the people who are setting up these standards are just beginning to come to grips with that, recognizing the problem and suggesting ways that you can deal with the problem. But in all cases, we're going to end up with an issue that our evidence is downgraded because of these difficulties in developing the evidence. So we're really in a difficult position in developing evidence-based guidelines using the standards that the methodologists in the Agree To group and the GRADE group are setting up. Not only, I think, is the problem that they set up, well, let me back up. So accuracy is still what they consider the very best evidence for diagnostic tests if you can't get outcome evidence, and you can't get outcome evidence. But I actually think that there's other evidence that's more important, and I can't go into this now. I don't think I really have time to do it and go over the rest of my lecture, but I think there's also other types of evidence that are very important in developing our guidelines that should be recognized by these groups and as yet have not been recognized by them. So the final issue, well, these are major issues in development of DI guidelines. The final issue is implementation. It's wonderful to develop all these guidelines, and we got all these guidelines, but what's the use of them if nobody uses them? And we know very well that basically in the past they were usually available in hard copy, and then they started to become available on the web. But we know very well that even if they're available in hard copy or on the web, there's very little utilization of them. Probably not enough to justify the amount of work that we put into them. So, and that's the first edition of the CAR guidelines were available in all formats. We had booklets available in English and French. They were available on various websites. We had a CD version available. But we don't honestly believe they were used very much. And I think that this is recognized by all the groups that are producing DI guidelines. And I think there's now a general consensus that the best way to get DI guidelines used is to integrate them into computerized order entry systems. And that, I think, in terms of the future development of guidelines, there are two things that I believe are coming in the future development of DI guidelines, I believe are coming. The first thing is integrating these guidelines into computerized order entry systems. And that has been done to some extent. We actually did some work in Manitoba. We had a couple of studies done in Manitoba using a computerized order entry system in which the CAR guidelines were integrated back in about 2000 and, I can't remember exactly. It's at least 7 or 8 years ago.
Around 2008.
I think it was around 2008, yeah. We did the first study at Children's. And this is just basically to give you an idea what the system looked like. The physician would go online, would put in the patient name or the hospital number. The system, the CPOE, was linked to the hospital admission and discharge system, so the patient demographics would be automatically populated, and then the physician would get a drop-down list of various imaging modalities, and he could choose, or she could choose from one of those, click on them, and then when they clicked on the modality they wanted, the exam and the modality, they got a drop-down list of signs and symptoms, differential diagnosis, and past history. And they had to fill in at least some of those. And the system would then take that information, match it to what it was ordered, what they had ordered, and determine based on the CAR guidelines, using a sort of simple computer logic, whether the requested exam was appropriate or inappropriate. It actually was very interesting software. This system was a bit complicated, but it was quite widely used in our hospital. Now, just going back. So here, the patient, the doctor has ordered a chest X-ray, and they've indicated that they're ordering it because the patient, they're worried about pneumonia and bronchiolitis. So the CAR guidelines say that if you're worried about bronchiolitis in a young infant, initially you should not be doing a chest X-ray. We don't recommend a chest X-ray in the initial investigation of a typical bronchiolitis. So they'd get that information, basically would be the comment taken from the CAR guidelines. In most children with wheeze, it's either the X-ray will be normal or uncomplicated. Well, we don't recommend it for asthma either. And so the recommendation is that you don't do the chest X-ray. And then the clinician had the option of going ahead with the chest X-ray anyway, or resetting the order, which would mean in this case that the order would be canceled. In some cases, the recommendation would be to use a different modality, to use MR instead of CT if they had ordered CT. And reset order would automatically change it to the recommended modality. So that's how our system worked. And most of the systems that are now available, and there are a few, look more or less like that. So is there any evidence that they work? Well, they didn't work very well at Children's Hospital. We had almost 9,000 orders go through the system, and about just over 10% were considered inappropriate. And I would say 10 to 20% is probably a reasonable range of inappropriateness. Well, not a reasonable, I shouldn't think it should be lower than that. But that's my guess, that if you looked across Canada, on average, that would be the range of 10 to 20%. And you can see that only in 2% of cases was the advice accepted. But when we tried it in Steinbach, in a family practice clinic, a much smaller study, slightly higher rate of inappropriate orders, but much higher rate of accepting the advice. So when you think about it, it's not too surprising that family practitioners are a lot more open to accepting advice than specialists. But there is evidence that this does work, and there have been other studies reported. This was a very large study from Mass General when they implemented a similar system there, and they looked at the rise in, so this is for CT and also for MRI, and they found that when they implemented it at this point here, that the CTs tapered off and didn't increase at the rate that would have been expected if there had been no CPOE. So they felt that implementing this system actually did reduce the number of inappropriate CT exams. Now, I think there's some question about this evidence because you see that the MRIs continue to go up, and you could argue that the CTs were being replaced with MRIs and there wasn't any change in the amount of imaging, but maybe the MRIs were more appropriate. But I think that I think the only way we're going to get these DI guidelines to work is to implement them into CPOEs. And there is, the ACR, the American College of Radiology, is very committed to this, and they have actually gone ahead and developed a system called ACR Select, which some of you may have heard of, which is, which incorporates their appropriateness criteria plus other guidelines into a computerized order entry system. And it really is a very good system. It's a very ingenious system, and I'm very impressed by it. I don't think it's the ideal system for Canada, but it is a very good system. And there's a lot of uptake of that system in the United States because a law has been passed in the United States indicating that if radiologists want to be paid through Medicaid or Medicare for their examinations, there has to be evidence that that examination actually was meets Diagnostic Imaging Referral Guidelines, or is compatible with Diagnostic Imaging Referral Guidelines. And that law is, well, initially it was supposed to come in 2017. I think they've delayed it a little, but clearly there's a lot of pressure in the States for people to use Diagnostic Imaging Referral Guidelines, particularly from the radiologists, because they're the ones that are going to be paid. And if there's no evidence that the guidelines were used when or referred to when the examination was ordered, they're not going to get paid. So they're really pushing ACR Select. And the European Society of Radiology recently signed an agreement with ACR Select so to develop a similar group of guidelines, or actually to modify ACR Select for European use. So there's a growing interest internationally in the idea of clinical decision support for diagnostic imaging, or computerized decision support for diagnostic imaging. Now, the other issue, major issue that I think is on the horizon and is only just beginning to be recognized in terms of diagnostic imaging, relates to clinical practice guidelines. This is an example of a clinical practice guideline developed by the American Academy of Otolaryngology and Head and Neck Surgery on the management of sinusitis. And this gives you an idea. I was talking about how detailed clinical practice guidelines are. So you can see that theirs addresses the issue of presumed viral rhinosinusitis, presumed acute bacterial rhinosinusitis, and chronic rhinosinusitis, and then how you diagnose it, and how you treat it, and so on. And in some cases, what you deal with treatment failure, how you prevent it, and so on. So clinical practice guidelines have a large number of sections and take a long time and a lot of resources to develop. But what I want you to notice is that in this clinical practice guideline, for each of these sections, radiographic imaging is part of that section. So this is what I think we have to recognize, that the days of developing diagnostic imaging guidelines as isolated imaging guidelines are numbered, because there's now software available that can start to integrate these much more complex clinical practice guidelines into EMRs, so that when a patient is admitted to a hospital, or when a family practitioner sees a patient in his office with sinusitis, he can actually open up these clinical practice guideline like this, and using that he can decide whether the patient has viral sinusitis, or whether he has acute bacterial sinusitis, and if he has viral sinusitis, how he should manage it, whether or not he needs radiographic imaging. And their recommendation is you don't need radiographic imaging if you can be sure clinically that the patient has viral sinusitis. And you should be able to distinguish clinically between viral and bacterial sinusitis. So we're not going to be able to sit back as radiologists and just say, well, we'll develop a guideline on how you image sinusitis. We're going to have to start talking much more actively with our clinical colleagues as to how diagnostic imaging is actually going to be fully integrated into a clinical pathway like this. And what is the role of diagnostic imaging? I think on balance this will benefit us. Well, hopefully it'll be a two-way benefit. We're going to get more involved in the actual role of diagnostic imaging in the management of patients. The people who are developing these guidelines will start to realize more fully how the problems of developing evidence for the use of diagnostic imaging in these clinical management pathways, and what kind of evidence we actually need. And but it does mean that as the software becomes available to implement these into EMRs, there's going to be much less need for isolated DI guidelines in computerized order entry systems, because people are actually going to be ordering their imaging as part of these clinical practice guidelines. And this is something that I don't think any of the radiology groups have really thought about. They do try to involve clinicians to some extent in the development of their guidelines, but not in any way like this. Almost none of the groups. The only group that has is the diagnostic imaging pathways. They have always approached their imaging pathways, their diagnostic imaging advice, in terms of clinical pathways. And if you go on their website and look at their imaging guidelines, this is what they look like. So this is actually a guideline for the investigation of suspect pulmonary embolus in a patient with pregnant patient. Sorry. So there are various steps you go through, including getting a D-dimer, and if the D-dimer is negative, you do this. If the D-dimer is positive, you do that. So this is really a clinical pathway, not a complete one because it doesn't include the total management of the patient, but this is actually very forward thinking, and this I think is where we are going to need to go with diagnostic imaging referral guidelines, and we're going to have to start figuring out how to integrate clinical pathways like this into electronic medical records and electronic health records. And the software is definitely starting to become available to do that. So basically what I've tried to do very briefly over this 55 minutes, talk about why we need guidelines, what are available, what are some of the issues in developing our guidelines, and what I see as some of the major future challenges of DI referral guidelines. Thank you.